Good morning, everyone. Can everyone hear me and see my screen?
Yes, we can.
Okay. I hope you're all doing well. Today's session, we're actually going to focus on surgical documentation and guidelines. And again, there's, a lot of valuable information to cover. So if we could just hold questions till the end, and then we'll have dedicated time to go over those. So your documentation is a crucial portion of coding, especially it's the first line of defense. It actually justifies the medical necessity and it ensures reimbursement. We want to make sure that we have clear, complete records to reduce denials and minimize the audit risk. Documentation must actually demonstrate and adhere to regular payer requirements. So, best practice, we want to make sure that we are being thorough and precise in clinical notes. We want to link documentation directly to the diagnosis and the procedures. You want to ensure timeliness and clarity to support smooth claim processing. Once a claim has been submitted to a payer, no, we can no longer perform any type of addendum, and it's not permitted. So we need to make sure that the documentation actually meets the compliance standards before we submit the claim. So your operative report, it's primarily used to process reimbursement for anybody, surgical team, your surgeons, and the facility. We need to make sure we clearly justify the medical necessity of the procedure. We want to provide a detailed description of each step of the surgical procedure and include surgical outcomes and results. When insurance payers request documentation, they will review that operative report. To request to confirm that all build codes are supported by this report. So, we want to, again, you're going to hear this a lot, but again, we want to make sure that we have accurate documentation. It's essential. So your report should include a heading section. You want to make sure that you have your facility name and location, the patient information, their name, their ID, demographics, the date of the service, surgery details. So that's going to consist of your primary surgeon, any co-surgeons, residents involved, surgical assist. And when we are documenting the surgical assist, if there is more than one in there, we want to make sure we are labeling as, the first assist, second assist, because most of your procedures, when you are billed, only allows for one assist. So the primary surgeon or the first assist is going to be the one that we would include to bill for those assist charges. You want to make sure that you have preoperative diagnosis codes, your postoperative diagnosis codes. You want to make sure that all diagnoses are applicable and are listed to support the medical necessity of that procedure. You want to make sure that there's a history indication. You want to explain why the surgery is necessary. You also want to describe the illness or injury that led to this surgery. Include any steps or treatments attempted before the surgery, if there was any applicable. You want to make sure how the illness or injury occurred, past medical history of the patient that's relevant, any family history that might impact the procedure, and any previous or failed attempts of treatment. So records record all steps from prepping to closing and dressings. If a procedure is bilateral, you want to make sure you're documenting both sides. Even if if it's noted in the heading of the procedure, you still in your procedure description need to make sure you're documenting both sides. Or if it's unilateral, make sure you specify the correct side. Additional details that could be included, the surgical approach. You want to make sure you're including that open or endoscopic. Any implants or devices, you want to confirm the implantation or items or list the items that that you addressed in the heading of the note. Robotic or microscopic use, as noted, if it was noted in the heading. any specimens that were collected, samples or frozen sections that were performed, any intraoperative checks or tests, document any portion performed by another surgeon. This is crucial. So we'll go over this when we go over co-surgeons, but this is actually really crucial. So just kind of keep this in the back of your mind. Um, and then the most important portion of your operative note is going to be the description of the procedure. This is the most crucial setting or selection of that operative report, because this is where the coders are actually pulling their information to assign their codes. And so there is a saying, just so you know, in the coding world, that if it's not documented in the procedure description, it is not done. So hence the reason why you may see a lot of your suspends, even though you have it listed under your procedure, the procedures that you're going to be doing or that you think you're going to be doing, if it is not in this procedure description, we cannot code from anything outside of that portion of your op note. So we can use your procedure list as a guide, but we cannot physically code from that procedure list. It has to be in the documentation of the description of the procedure. So kind of keep that in mind. If you see that you have something listed in your procedure list, you're going to want to make sure that it is in the procedure description if you truly, in fact, did do it. Because if it's missing, it can lead to, obviously no reimbursement for the procedure. It could be that the insurance is going to recoup the payment back from you guys. Providers should not include procedure codes. So it's not to say that you can't include your procedure codes in there. We don't recommend it unless you are a self-coding provider. And because it adds, it could lead to incorrect billing. Documentation may not support those codes, which could cause, compliance issues. You want to make sure that you are listing findings and follow up. You want to provide a brief overview of what was discovered during the surgery. You want to focus on the main surgical outcomes. You want to document any complications that occurred during or after the procedure. If there were no complications, you want to clearly state the absence of that. Any follow-up treatment, you want to make sure that you have, additional treatments or stage surgeries that may be needed, and include details about the planned future interventions. So, I'm sorry, I just want to get this down. An assist at surgery is a physician who actively helps the primary surgeon during the procedure. Their involvement actually goes beyond the basics of the ancillary task. The operative note must clearly state what the assist did during the surgery, and this will actually be the primary surgeon's responsibility for documenting what they did. There is no need for an assist to do any of their own separate documentation. Medicare guidelines, the fee schedule includes status indicators for assist at surgeries. These indicators show us whether a procedure code allows for a second surgeon, or even if they allow for an assist. Most insurance payers do follow CMS guidelines, but some do have their own rules. And so in a case like that, if they were to have their own rules, the commercial insurance would trump Medicare's guidelines at that point, just so you know. We have Modifier 80, which we use when a medical doctor provides a surgical assist during a procedure. Modifier 81 would be for minimal surgical assist by an MD. And then 82 is for when a non-qualified resident is available, and an MD assists instead. Documentation must clearly explain why a resident was unavailable. If the MD simply prefers not to use a resident, this preference must be documented as well. The AS modifier is when we have a physician assistant, a nurse practitioner, or a clinical nurse specialist that provides the assist. And that AS is only valid for non-physician assistants, so not used for the MD. These are the assist at surgery payment indicators. You will see, so this is how we determine when we put a CPT code into our Encoder Pro, which gives us all of the Medicare guidelines and all the information, description of the procedure and whatnot. This is how we determine if the CPT code allows for an assist. If it has a zero, the medical necessity for the zero restrictions, so we do not normally bill out anything with a zero because the documentation has to go above and beyond what a normal assist would do. And when I say it's very lengthy and it's very hard to get paid. So Tenet normally goes by when there's a zero payment indicator, we do not bill for an assist. Statutory payment restrictions, it says no appeal allowed. So we will submit it with the assist information in there because they will come back and request the documentation when they see this payment code. We will submit the notes for them and they may or may not pay for it. If they feel that it's allowed, then they will go ahead and pay. But most of the time, they do deny it because, for example, a lower extremity duplex scan or vascular angiogram, a lot of times, we do have assists in there. And it's mostly because, providers are learning. But even though they document it, that is one of the examples. We will submit the notes, but most of the time, insurance companies will come back and say, this doesn't support for an assist. So, and unfortunately, we can't even appeal those ones. So payment indicator 2, restrictions. So this here, when a surgery has a payment indicator 2, that states that particular CPT allows for an assist, so they will go ahead and pay it. And most of the time, they don't come back asking for the notes for this, unless it's something above and beyond what they normally see. Your category 9 is a concept. This does not apply. So we don't see this mostly in the assist world at all. So they're very far and few when I tell you that CPT codes have this. When reporting, modifier 80 and 81, Medicare fee schedule allows up to 16% for the surgical payment. When reporting with an AS, Medicare allows 85 of the 16 for the assist. Here is an example of what the documentation should look like when the assist, is present. You want to actually make sure you put the assist name and then their credentials, that they were the first assist throughout the case. You want to make sure that you put that no qualified GME resident or fellow was available. And then you're going to go in and, document exactly what the assist did. When we talk about co-surgeries is, two surgeons that work together on the same patient during the same operative session, typically for complex procedures or due to the patient's condition. But documentation requirements are a little bit more involved in this. Each surgeon must create their own independent operative note detailing the specific work that they performed. Notes must clearly reflect each surgeon's distinct contribution. So if you are doing your own note, you still have to reference your co-surgeon and what they performed in your documentation as well. And then both surgeons must append modifier 25 to their claim. The procedure code and the diagnosis code must match on both claims. So kind of keep that in mind, because we do see a lot where the diagnoses are not matching. And again, here are your co-surgery payment indicators. Your 0 is co-surgery isn't paid, can be paid with medical necessity, and then co-surgeons are permitted for 2. And then again, your 9, we don't normally see this, but reimbursement is 62 of the Medicare fee schedule. So, teaching and physicians, when services involve residents, the teaching physician must personally document specific details. You want to confirm that the teaching physician performed the service or was physically present with the resident during the key or critical portions of that procedure. Document the teaching physician's active participation in managing the patient's care. And here we have some acceptable attestations. You want to state that I was present with the doctor resident during the history and exam. Of course, this isn't going to, it's going to be more of your findings for your surgical. Um, Let me see if we've got that. They don't have that in this slide. Of course not. But you want to state that you were present with the resident during the critical portion of the procedure. And then we have attestations. So when we are doing attestations, if you do not perform it on the same day, you want to make sure that when you do your attestations on any note, um, that you are reflecting in your attestation the date. So if you're doing the attestation the date after the procedure, or even your documentation for E&Ms, you always want to make sure that you are reflecting in your attestation the actual date of surgery or the date of the office visit. And then moderate sedation. So Medicare generally allows for separate reporting for moderate conscious sedation. On the professional side, you can actually get the first 15 minutes of moderate sedation, but there are guidelines and there is guidelines for documentation. So when provided by the same physician performed a medical or surgical procedure, except when the anesthesia service is bundled into the procedure. So radiation treatment would be an example. Moderate sedation services provided by the same physician or other qualified healthcare professional performing a diagnostic or therapeutic service that the sedation supports, requiring the presence of an independent trained observer to assist in monitoring the patient's level of conscious sedation. The physician who is performing the procedure, obviously, you cannot be monitoring the sedation at the same time. That's the reason why they are saying an independent trained observer has to be doing that. But you could document who that person is. And you could also document, you're going to need to document the route the IV was given, most likely it's IV. Any names of medications that were administered and a start and stop time or a total time in your statement. And then, so in your documentation, and then a statement that states that the sedation was administered by the trained observer, and you can give their credentials or name under your direct order and supervision. Any questions? No questions?
Can you give an example of co-surgery? Like the first thing that come to mind is we have a patient who's on the floor. She came in with multiple burns. The burn surgeons did something, and then our team did something else at a different anatomic location. Is that an example of co-surgery, or is it at this?
No.
It's the same
So,
anatomic location?
no. So you're seeing them. So you guys are not, were you guys in the room together doing that surgery?
Well, they did their procedure, and then we did our procedure.
Okay, so an example would be, and so co-surgeries are very kind of complex. So you have two different surgeons from two different specialties in the room. One is performing one portion of the procedure, and the other would be performing the other portion of the procedure. Now, keep in mind, both providers must agree to do co-surgery. So, for example, if you take TAVRs. Normally you have a cardiologist and you have a vascular provider in there. And normally those procedures are performed as co-surgeries because the cardiovascular provider is performing one portion of that, that procedure, and then the vascular would be performing the other portion of it. But both of you have to agree to bill it as a co-surgery. So even though you guys were anatomical, if you guys were not, the procedure was not booked together with both of you doing that portion, then it would not be considered a co-surgery. Even though the anatomical site was the same, you're better off in that case billing your own separate opposed to the co-surgery. There are certain procedures that how can I explain this? That Medicare considers co-surgeries. Outside of that, and there's only a handful of them, believe it or not. Outside of that, they normally would recommend that you bill your own procedures opposed to your co-surgeries. And reimbursement is actually better when you do it non-co-surgeons. I can't tell you that. Does that make sense? It's very hard to kind of give you a scenario outside of cardiology because the most of your vascular and cardiology procedures are the ones that are considered co-surgeries. But it has to be two separate specialties.
Understood. Thank you.
Mm-hmm. Any other question?
Hey, Renee, this is Steve Slotkin. I have a sort of follow-up question regarding co-surgeries because in our world, we do this. And I was kind of curious about this. So the application for us would be a kid who has, for example, like cerebral palsy, and they have, let's say, bilateral hip issues. And so for ease of surgery, much faster, basically half the time, two of us will perform literally the same operation, but on either side of the body. So we'll sort of do these femoral osteotomies and pelvic osteotomies. Let's say I do one side, and for example, Dr. Hedrick or Dr. Demowski will do the other side. So we do them routinely, and that would be a bilateral procedure. So are you saying that
So
we
in a
should
case
code
like
them?
that,
So we should code
that's
them as co-surgeons or
correct.
individual?
Correct. So depending on the CPT codes, if it allows for a co-surgery, then yes, we would want to bill that as a co-surgery. You would obviously document your note with what you did, but also you would want to make sure you reflect what the other provider in there performed on the opposite side. And it doesn't need to be in detail, but you just want to make sure that you are speaking to the other provider in your note and what they had, generalized what they performed.
Sure.
And then the other
yeah.
provider would do the same thing.
Great. So that's helpful. And then the other sort of the other application of this would be some of our more fragile scoliosis patients. So again, as opposed to like the hip example I gave, where there are two separate sides, some of our spine patients that we do the same procedure, but on either side of the spine. So for these scoliosis patients, it's much more efficient. It's actually been proven to have better outcomes with two surgeons, especially for these neuromuscular kids, to do them on both sides. But because it's not as clear cut as like a right hip or a left hip, is that the same concept for it, or is this is this harder to kind of bill for co-surgeons, or like what do you think is the better way of doing that?
Well, again, it's going to come down to the description of the CPT codes and what Medicare's guidelines state as to whether or not a co-surgery is acceptable. So in a case like that, if you really have questions when you come up with one, and you have an example, you could send me the CPT codes or the description so that I can look at the operative report and we can actually look at the CPT codes and tell you which way is going to be beneficial and if co-surgeons are even, allowed in that procedure. So that's the thing. Without you guys actually being able to look at the CPT codes and what they allow, you're not going to know either way. But I can tell you that, I mean, because Nancy has taken over for you. If that is the case, when she codes your procedures, for a case like this, and she sees that co-surgery is allowed, she's going to email you And she's going to tell you that this allows for a co-surgery, and that, we just need you to perform an addendum to include, the work of the other provider.
Yeah, so historically, that's what we've done for these neuromuscular ones, for example. We've always done this when there's two of us that are doing it. And to be honest, we would continue to do it regardless of the compensation because it's shown to be better outcomes for these patients and their surgeries are faster, less blood loss. So it's more just for us, we're doing the right thing. It's more just getting compensated for the work that we're already doing. And so again, I get it. You're saying like, it's good to know whether you're getting compensated or not appropriately. We just keep doing it. So my question just is how we go about it from the other coding side of it to support what we're already doing. Because it's one thing, it's like, yeah, fine, like we're still going to do it regardless of how the conversation goes because it's better for patient care. But it would be good to have something on the backside from the or from the coding side to say, hey, listen, we need to support this because it's proven in the literature to have better outcomes and better support.
So I could suggest that when you are documenting, that you document it as a co-surgery note. You each do your own, your own notes, documenting it as a co-surgery. And the reason why I say it this way, because if it is allowed for a co-surgery, then obviously we would bill it and your documentation supports it. If it doesn't allow for co-surgeries at that time, your note still supports it. You both have your own separate note anyway, of the procedure description of what you guys had done anyway. And so it's not gonna, the claim wouldn't deny if we had to send the medical necessity over. So the claim wouldn't deny even if you had addressed it as a co-surgery. Um, and in a case like that, again, Nancy the coder will reach out to you and say, okay, well, if we're going to bill this as a co-surgery, one of you might need to perform an addendum because the diagnosis doesn't match. Because remember, you both have to have the same diagnosis in your note, to reflect it as well. But she would reach out to you anyway to tell you. But the best scenario I could tell you to do would be to document it as a co-surgery. So each of you do your own note and just speak to what each of you performed in your notes.
Okay, sounds good.
Anything else? Any other questions? So next week, I will be meeting with you guys next Friday as well, to go over my beloved fracture care. So that one will be interesting, but if nobody has any other questions.
Hey, Renee, I have that one set for the 30th, but I can change it to next week if you want.
No, that's fine. We can push it to the 30th because this one is gonna, this one I think is gonna ruffle some feathers. I hate to say it that way, but so yeah, no, the 30th is fine. I will be prepared, but if there's no other questions, do you want me to send the slide deck to you?
Yeah, you could definitely send that to me.
Okay, then I will go ahead and send the slide deck over, and then I will talk to all of you guys next or on the 30th, and I hope you guys have a wonderful day.
Thank you as well.
Thank you.